This recorded lecture will be going over Chapter 33, The Child with an Emotional or Behavioral Condition. Assessing child-parent relations is an important and ongoing aspect of care. The term intellectual disability has replaced the term mental retardation. The onset occurs before 18 years of age. Nurses should keep a careful record of behavioral and note relationships with members of the family and classmates. Every day, everywhere, children are trying to cope with stress. A recommended communication strategy that parents can use is help. They should offer hope, demonstrate empathy and loyalty, and participate with the family to have a consistent plan of care. Nurses must be aware of resources in their community in order to effectively guide parents. Most children will consciously and unconsciously identify with parental values. If the healthcare provider discredits the parent's values, it will threaten the child's security and create anxiety. Because children do not seek treatment on their own, the nurse should assist the parents in becoming invested in the treatment modality established for their child. The basic staff of the Modern Child Guidance Clinic is composed of a psychiatrist, a psychologist, a social worker, a pediatrician, and the nurse. Children who do not respond well to individual outpatient therapy may require the type of care provided in residential treatment centers. The length of treatment for the child will vary from 1 to 3 months. Interventions can be direct or indirect, and they may involve individual, family, or group therapy, behavior modification, or MILU therapy. Finger sucking, nail biting, excessive fears, stuttering, and conduct problems are often reflections of nervous tension and anxiety that could stem from a dysfunctional family. Identifying risk factors and advocating early intervention are major goals of children's mental health services. Early bonding and attachment are essential parts of developing positive mental health. Children must rely on adults for their experiences and the environment. The main goal of therapy is to assist the family to promote an optimal level of functioning. An area of specific focus in neurodevelopmental function is academic skill development, like learning disabilities. Learning disabilities will include a difficulty in reading, spelling and writing, and mathematics, skills necessary for success in school. The diagnosis will be made when the school-age child experiences academic problems and is given tests to evaluate intelligence and academic skills. The child will then be eligible to receive special education services. Dyslexia is a language-based learning disability characterized by difficulty in sounding out words, word recognition, and reading comprehension. It is a common learning disability, and if left untreated, it can affect academic success and psychosocial well-being, as well as result in behavior problems. Dyslexia is often seen in children with ADHD, but it is not a part of the pathology for ADHD. Early signs could include difficulty in recognizing letters of the alphabet, difficulty in learning nursery rhymes, or confusing words that sound alike, resulting in a dislike for reading. Individual and family counseling is helpful, as is specific medication that may be prescribed. Autism spectrum disorders are a group of neurodevelopmental disorders characterized by difficulties in social interaction and communication, repetitive behaviors, and stereotyped interests and activities. ASD includes formerly separate conditions like autism, Asperger's syndrome, Rett syndrome, and others. The cause is thought to be related to factors like close spacing of pregnancies, advanced parental age, prematurity, prenatal environment, and multiple genetic factors. The diagnosis can be made as early as 1 to 2 years of age and is well established by 18 years of age. In early childhood, there is evidence of little pretend play, the use of rigid rules in play, or a preference for solitary play. Red flags to report would include no babbling or pointing by 12 months, no 2-word spontaneous phrases by 24 months, or a loss of social skills or language that was previously attained. Routine screening before 2 years of age during scheduled clinic visits is advised. Management of ASD involves providing well-structured home and school environments, behavior modification, and the use of specific drugs to manage specific behavioral problems. The drug therapy of ASD will not be curative. The nurse's approach to the patient should be slow-paced with few distractions. Permission should be asked of the child before touching them, and sudden movements or loud noise should be avoided. With obsessive-compulsive disorder, a recurrent, persistent, repetitive thought invades the conscious mind, and a ritual movement or activity assumes inordinate importance. The compulsive behavior response to the obsessive thought may interfere with daily activities and cause academic problems. The behaviors could start as early as 4 years of age, but they may not be noticed as interfering with daily functioning until 10 years of age or older. OCD does not involve an impairment of cognitive function or interpersonal relationships. Cognitive behavioral therapy, combined with medication, will provide for the best results. Parent and sibling involvement and support are essential. The nurse's role is to assess normal growth and development and to understand the ritualistic behavior is normal at 3 years of age, and it will typically be replaced by hobbies of collecting and special interest by 8 years of age. Attention deficit hyperactivity disorder refers to a developmentally inappropriate degree of gross motor activity, impulsivity, and inattention in the school and home setting that begins before 7 years of age, lasts more than 6 months, and is not related to the existence of any other CNS illness. The child will often underachieve in school, have problems with interpersonal relationships, and low self-esteem. The childhood criteria for the diagnosis of ADHD includes at least 6 symptoms. Some of these are receptive language, expressive language, information processing, memory, motor coordination, orientation, and behavioral problem symptoms. Some symptoms also include inattention, impulsivity, and hyperactivity. Early detection, diagnosis, and treatment can prevent long-term adverse effects of ADHD. Treatment is individualized, with the main focus on CBT and appropriate medication when indicated. Various support groups can aid parents in their coping skills. Anorexia nervosa is a form of self-starvation seen mostly in adolescent girls. This disorder can be characterized by a failure to maintain the minimum normal weight for age and height, an intense fear of gaining weight, an excess influence of body weight on their self-evaluation, and amenorrhea. They may have a low self-esteem, are obedient, and are non-assertive and shy. Families of these young people are often dysfunctional. There is often a power struggle between the child and parent. Children may feel that the only thing they can control in their environment is what they put into their mouth. The primary symptom of anorexia nervosa is severe weight loss. Adolescents with anorexia experience feelings of helplessness, lack of control, low self-esteem, and depression. Although eating less, the anorexic individual is preoccupied with food and its preparation. A brief period of hospitalization may be necessary to correct electrolyte imbalance, establish a minimum restoration of nutrients, and stabilize the patient's weight. Therapies include individual and family psychotherapy and a biopsychosocial model of behavior therapy. Nurses working with adolescents in any capacity should be alert to the symptoms of this condition. The core of treatment is maintaining general health in addition to a healthy diet. Medications like SSRIs will often be prescribed to manage the symptoms of depression. Complications include gastritis, cardiac dysrhythmias, inflammation of the intestine, and kidney problems. With effective treatment, 80% of adolescents with anorexia nervosa will resume menses, have restored fertility, and can avoid long-term cardiac complications. Bulimia, or compulsive eating, is recognized by the DSM-5 as a binge eating disorder. It is characterized by recurrent episodes of uncontrolled eating of more food in a short time that is considered normal, followed by self-induced vomiting and the misuse of laxatives and/or diuretics on a weekly basis for more than 3 months. Family dysfunctions are usually present in children with bulimia. Impulsive behaviors are characteristics of adolescents with bulimia. The HEADS format of interviewing adolescents is helpful in obtaining a detailed assessment. This includes the home, employment or education, activities, drugs, sexual activity, suicidal ideas, and safety. The nursing role in coping with adolescents with eating disorders is to educate, prevent, identify, and refer. The nurse should maintain a supportive and respectful but firm manner. Disruptive mood regulation disorder is characterized by a daily, persistently irritable or angry mood between the ages of 6 and 18 years that lasts more than 1 year and is evident in both home and non-home settings. ODD is described as an ongoing pattern of anger-guided disobedience or a hostile or defiant response to authority that lasts at least 6 months and occurs in the home and school or with peers. This can start as early as 3 years of age. Conduct disorder is characterized by behavior that violates the rights of others or the rules of society and lasts more than 12 months. Internet gaming disorder involves compulsive internet gaming that excludes other interests, endangers academic or employment, and results in withdrawal symptoms if stopped. Gaming elicits a neurological response that provides a sense of pleasure and reward, which can result in addictive behavior. A social anxiety disorder will often involve distress that impairs functioning. Separation anxiety is not developmentally normal when it occurs in the school-age child. Older children will refuse to go to school, and a panic disorder may develop. Depression is an emotion common to childhood. A major depressive or mood disorder is typically characterized by a prolonged behavioral change from baseline that interferes with schooling, family life, and/or age-specific activities. Inheritance factors, organic factors, and environmental factors will all contribute to major depressive disorders in children. Nursing responsibilities include recognizing the signs of depression and initiating appropriate and prompt referral. You can read a little bit more about this in Nursing Care Plan 33.1 on page 772. Cognitive behavioral therapy focuses on problem solving and emotional management skills and may be combined with medication. SSRIs are well tolerated by adolescents with anxiety disorders, but the FDA warns of the development of agitation and suicidal thoughts when these drugs are used with major depressive conditions. Suicide is the third leading cause of death in adolescents after accidents and homicide. Some adolescents may exhibit rage behavior or an emotional outburst that results in an impulsive act that could result in accidental death. Mental health associations, hotlines, drop-in centers, safe houses, and free clinics are all community resources that can be helpful to use. Substance abuse is the illegal use of drugs, alcohol, or tobacco for the purpose of producing an altered state of consciousness. There are two types of dependence, psychological and physical. Drugs of abuse will often have nicknames, and you can see some of these nicknames in Table 33.1 on page 774. Almost every drug of abuse will harm some tissue or organ in addition to the brain, but the developing brain of the child and adolescent may suffer more injury than the mature brain and organs of the adult. Studies have shown that many 8th grade children have experimented with beverages containing alcohol. Alcoholism is often a family disease. Gateway substances are common household products and alcohol that can be abused to achieve an altered state of consciousness or a high. Asthmatic children can have serious reactions to marijuana due to the bronchoconstriction that occurs when smoking the substance. Adolescents who abuse drugs will often drop out of school, and the sharing of unsterile needles will place the adolescent at risk for contracting the HIV, hepatitis virus, and other infections. The prevention of substance abuse begins by helping expectant parents to develop good parenting skills. A positive self-image and feelings of self-worth will help adolescents fine-tune their adaptive coping skills. Clinical experience in substance abuse treatment settings has shown that many adolescents become interested in treatment and make behavioral changes after they have been required to enter a treatment program. Pediatric nurses are in an excellent position to recognize and intervene in cases in which physical or emotional neglect exists due to parental alcoholism. Children of alcoholics are often confused by the unpredictability of family life. They are at a high risk of emotional and physical abuse, including sexual abuse. Children of alcoholics are also strong candidates for becoming alcoholics as adults. 4 predominant coping patterns of children of alcoholics are flight, fight, the perfect child, and the and the super coper or family savior. You can see a depiction of this on page 776 within figure 33.3. Some clues that may or may not be related to this problem include a refusal to talk about family life, poor school grades or overachievement, an unusual need to please, fatigue, passive or acting out behavior, or maturity beyond the child's years. Knowledge of normal growth and development throughout childhood, combined with good observation and listening skills, can enable the nurse to play a major role in minimizing the negative impact of behavioral problems on growth and development. Most siblings of children with emotional disorders will either suffer emotional scars or develop protective coping mechanisms to handle their experiences. Sibling rivalry is a competition between siblings for the attention or love of parents. This is a normal part of growth and development, but guilt on the part of the other sibling can enter the picture when one sibling becomes ill.